Yesterday we talked about the burn and the calculation. So I want to demonstrate it again so that you guys can get used to it. Then when you see a question, so I'll draw my caricature over there. You have to be able to know this. And then there's a box that is the front and the back. And that is his hand and his head. So his head is 4.5. This includes the neck. So 4.5, that's the front. The upper extremity is the left side. The front is 4.5%. This one too is 4.5, the whole front portion of it. The thorax, which is the abdomen and the chest, the front is 18, the back is 18. So I can put 4.5 over 4.5, and this is 4.5, that's half of it. And this is also 4.5. The leg is usually, anterior portion is 9, the posterior, that's the front and the back, 9 and 9. And then the perineum is just 1. So when you add, you should get 100%. That is the rule of 9 for burn patient. And then to calculate how much fluid they need, you got to use the Parkland formula. I'm just being straightforward. So what you need is this is the constant, 4 ml times the patient weight in kilos times the total body surface area that was burned. This one you have to calculate. And this will give you, the fluid you get is the fluid for total for 24 hours. Fluid for 24 hours. But in burn patient, the first 8 hours, you have to give them half of the fluid that they need. So 8 hours will be half of the 24-hour fluid that you need. And then the rest will be given over 16 hours. So the half also go of the times the 24 that fluid you needed. So you can see that the rates are going to be different. The rate in the first 8 hours will be very, very high fluid. And the rate, the 16 hours will be a little bit lower compared to the first one, the 8 hours. What fluid you need to use? This is very important. If you don't know anything at all, this you have to know. If it's give you a multiple choice question, burn patient, and that need the fluid, your fluid of choice is a lactate ringer. Don't give them normal saline. Never give them normal saline. This causes metabolic acidosis. I try to teach like you are in the office working. This is clinical. So if you are working, they give you a patient and a doctor ordered normal saline for a burn patient. This is something you have to question, because the patient will develop metabolic acidosis. Therefore, because you're giving them large amount of fluid, they will need probably like 10 liters in a short time. It will become acidotic. So the fluid of choice for a burn patient is a lactate ringer. That's what you give them. So that's the first information about that I want you to know. So this is a brief summary of what we did, and I'm going to add some few information. So this is, you got to know how to calculate this, and then you have to know how to information about burn. There's few things I want you to pay attention to. So burn, usually, if somebody come and present to you, he had a burn wound to the body. There's stages, okay? So the first stage is something we call resuscitation stage or resuscitative state. That is the state within 24 to 48 hours. This is where you're resuscitating them. What is your priority? When they ask you for priority for a burn patient within 24 hours, airway. airway is your number one priority, followed by IV fluid. So IV fluid is number two. So airway is number one, then IV fluid resuscitation, because they have lost a lot of water, is number two. And you control their temperature. This is where you control temperature control. And then you ensure that their circulatory volume is normal. So monitor their hemodynamics, basically. But the most important is airway during resuscitation. So when they give you a question, sometimes they refer to the timeline. This point, airway is number one, followed by resuscitation as number two. The next stage is, usually we call it acute, but it's very confusing. The resuscitative state is the early stage, followed by the acute state, which is usually 48 hours, after 48 hours to 72 hours after. This is where they give you all the fluid you've given them. So they start to diarrhea. So they give out their fluid. They start peeing more. And your number one here is nutritional support, so that the wound can heal. Nutritional support, but you also continue to monitor their hemodynamics. So this is where you worry about. But number one is nutrition, followed by wound care. You got to start taking care of their wound. So you got to stay taking care of their wound after. So wound care is very important here. Then stage 3 is the rehabilitation. This is very, very long. It can take up to like several years, sometimes 1 to 2 years, you know. So this is after 72 hours till, I mean, it can go all the way to 2 years. This is where you're trying to prevent contraction, okay, wound contraction, and then bring them back to their normal state. This is where you do like multiple surgery to revise the skin, the scar, okay, multiple surgery that will revise all the scar that has happened. I mean, so you got to get comfortable with this kind of information, especially if they ask you in the new generation, this is what is happening. And this is a long time. This is where emotional portion of it, you got to provide a psychiatric evaluation, PT, OT, people involved for to improve the patient function. Okay, so this is where you do the OT and PT information and everything. Can everybody hear me? Like, there's a message. Okay. So these are the quick 3 stages and what you, the nurse, supposed to do. Stage 1, resuscitative within 48 hours, airway, then resuscitate them. Secondly, after 48 hours, they're going to give you all the fluid that they've taken from you. Then after that, you rehabilitate them. This is where they like asking this question. They will ask you some of the lab work. So think about it. So the patient is burned. The skin is exposed. Your blood cells died. It's like rhabdo. They die, they burst open. Potassium is usually more inside the cell. Okay? And so when the cell bursts open, potassium comes outside. So potassium is released. So these are electrolyte, initial electrolytes that you have to be aware of when a burn patient presents. Their potassium is very, very high. So you have to know this one because of the destruction of cells, right? They are in stress. That is a lot of energy, stress. So steroids are released, epinephrine, all the stress hormone is released by the adrenal gland. Therefore, you should expect their glucose to be high. It's a stress hormone. The skin is completely denuded. So there's nothing there. They will lose a lot of fluid. So they dehydrated basically. So they are hematocrate. They will have something we call hemoconcentration. So their hematocrate will be higher than normal. If they give it to you, it will be high. RBC, I think you try to remember these things. They like to trick you. It's higher than normal. Okay. And then they're going to be in a different acidotic state. The kidney, because the kidney is in trouble, is not getting more any fluid, the kidney will be trying to shut down. You develop metabolic acidosis. So they will have metabolic acidosis. This is the acid state. So metabolic acidosis. So these are the states you should be more concerned about. And the sodium is low. I want you to remember this lab work. High potassium initially, glucose is high, hemoconcentration, metabolic acidosis, and low sodium, the first time they present. As you go to the acute phase, that's when things changes. Potassium they go down because now the body is pulling the fluid back into the system. So potassium go down. Glucose can be high or low because now they are still in the stress state. This all will then start going down after 48 hours because now fluid is being shifted into the bloodstream. So hematocrit go down, RBC also go down. The metabolic acidosis now normalize. It become normal. This tend to be normal. And sodium will get still more and more down because fluid is now being moved into the cell, into the extracellular fluid, and they will get fluid overloaded and they will start to pee all the fluid out. So try to remember this. Is the opposite is what happened after 48 and 72 hours. Okay. Any question? Let me see. So those are simple questions they like to ask. What happened when a burn patient present right away? And then they try to trick you and all that. It's just a straightforward question. Then I want you guys to remember this. So the potassium is because the cells are dying. The red blood cells burst and everything, all the tissue that die from the burn, they release their content. So potassium is going to be high initially, the first when they present. So potassium is very high. The kidney, they dehydrated. So the kidney function goes down. So the blood level, they will develop what we call metabolic acidosis. When your kidneys shut down, this is the kind of acidosis you have, metabolic acidosis. And then because they're losing all the fluid, they will have hemoconcentration. What it means is the blood is going to get thicker. So hematocrit will go up. RBC will go up. Because they've lost a lot of fluid into the extracellular fluid, into the tissue and out of the body, and sodium is also going to be low. Okay, and then the stress from the burn, you release stress hormones like epinephrine, norepinephrine, adrenal gland, all the content will be released, and so their glucose will be high. Your body, whenever you're stressed, you have hyperglycemia. This is what happened during the resuscitative state, which is 24 to 48 hours. After 48 hours, remember, we've calculated the fluid they need. So all those, they will need like sometimes 10 liters, 12 liters. All the fluid you give them go into the tissue still because of the edema. Then after 48 hours, they will say, okay, and now I need to give you back your fluid. So they start giving you all the fluid. So fluid is now going back into the extracellular fluid and system. So potassium get diluted. So potassium go down. The kidney metabolic acidosis will resolve because now they're happy. They get more fluid now. The blood concentration, hemo concentration will be hemodilution. So it get diluted. So hematocrit will start going down. And the RBC also go down. There's more fluid going into the system now. Sodium will continue to go down until they pee all the fluid out. So sodium goes down. The glucose, they're still in the stress form. So they can be normalized or still in the higher form because they have not get out of that stress yet. It can be high or low, depending on what kind of question they give, but mostly on the high side because they stress. So those are what happened within 24 and then after 48 hours, this is what happened. A little bit of small farm, these medications you have to know, these straightforward for burn. You see it in your questions. They are not hard. I'll just tell you what we use it for. So you see Silvadene, you hear about Silvadene. This is a sulfur drug. What they will ask you is, what do you do when you give the patient Silvadene? They become neutropenic. So WBC go down. Because of that, you have to be careful. You have to watch the CBC. You need it for the burn, but it's very good. It's one of the biggest medication we use, Silvadene, for any patient who have a burn wound. What you have to know is caution. This, don't put it in the face. This is like live, okay? Not in the face or in the eyes. Injury. So this, when somebody have a burn wound in their face, if they have a burn in their face, you use Bacitracin. So don't put Silvadene in the face or the eyes. That's all. That's the only thing I will tell you about this, man. That's the only thing they can ask you about. Side effect, neutropenic or white count going down. And then which areas you should not put in the face and in the eyes. The other one is Mafenide. This one causes metabolic acidosis, Mafenide, metabolic acidosis. And we don't use it. If you have to dress the wound, never use this. Don't use it for dressing because of the metabolic acidosis. So use Silvadene or Bacitracin. You can use Silvadene in the face. Then we have silver nitrate. This one, no side effect, so it's good. Then you have Bacitracin, no side effect. The best one for the face is Bacitracin. The best one for the body is Silvadene. And Mafenide, and you don't use it because of metabolic acidosis. Silver nitrate, once in a while, some people will alternate with that. And that's all. That's what I want to say about this. Less information as much as possible, but this is straightforward. These are their side effects. This is when condition you use them and the condition you should not use them. Bacitracin is good for the body, but the best place is the face. Use it for the face because Silvadene is the best for the body, the whole body. When somebody have a burn wound to the whole body, and there's your choice, they give you choice, I'll put Silvadene. That's the number one. But if they have a burn to the face and the eyes, well, then you got to use Bacitracin in the face and the eyes, and the rest of the body, use the Silvadene. Okay, and this is all about burn. Let's do the calculation, then we will call it a break on that. Okay, any question on this medication? simple for pharmacology that you should just know straightforward. So yesterday we did this calculation, and so we're going to demonstrate. I wanted you guys to pay attention, like really, it's not that hard, okay? So, but you have to know how to calculate it. So let me draw my big boy caricature here. So they say a 50-year-old man has a partial thickness burn on the posterior. You have to be careful. Posterior head. So that means what? The back of the head. So posterior head. That means back of the head is 4.5. So posterior head and the neck. So 4.5. Front of the left arm. So front of the left arm. So front of the left arm is 4.5. Front and back of the right arm. So front, back, right arm. That means the front is 4.5, the back is 4.5. So we have 9. When you're reading this, you got to be careful. Don't just rush through. Posterior trunk. That means the back, the whole back. That means posterior trunk is 18. Front, back of the left leg. So front of the left leg is 9. Back of the left leg is 9. So 18. Front, back, left leg is what? 18. Where am I now? I'm lost. Front, back of the left leg. And then back of the right leg. I intentionally said it this way to confuse you guys. So back of the right leg. What would it be, guys? Somebody can. So when they give you something like that, just be careful, because sometimes they say front to back and you only pick one. And then we add all of them. What do we got? And let's move this thing. We got to add all of them. 63, okay, somebody. So total body surface area that is burned is 63%. This patient is not going to survive. This is a black. If they ask you, if they give you this, who do you see first in the trauma? Getting over 60% is a black patient. Don't even think about it. Don't pick it. It's a black. The patient weighs what? It's 91 kilos. So weight is 91, which we don't need to convert because the weight is already in kilos. Use the Parkland formula to calculate what? Total, this one, you have to be careful. Sometimes they want the first 8 hours or 16. This one, they said total amount of lactate ringer that will be given in 24 hours. You see, they put lactate ringer there. I intentionally put it, 24, so that you know you only use lactate ringer the next 24 hours. So Parkland said what? 4 ml times the weight in kilos, which is 91, times total body surface area, 63. So we're going to get what? Okay, that's a lot. 22,900 and what? 32. What? ML of fluid. This is 22 liters. You see, if you're giving a patient 22 liters, you're going to pulmonary edema. This guy, that's why this burn patient is really bad problem. When you burn yourself, this is why the electrolyte happen. When you burn yourself, it's bad problem. You have to correct the burn. If you don't give them fluid, they die. So we got to give them fluid. And when we give them fluid, the complication is intubation. They have to be intubated. So airway issue because they go into pulmonary edema. So look at how much this patient needs. This is what you need to give in 24 hours. That's bad. more than almost 4 times of your body, your blood volume. You know, your heart cannot take it. And this is how you calculate this, you know, straightforward. Any question on that? Then different format, but same idea. 45-year-old deep partial thickness burn to front and back of the right and left leg. I'm trying to get you guys to be comfortable with the way they will set it, to confuse you. Front and back. So you see the way I'm writing it, this is the way you should do it. Front, back of the right leg. That means what? 18, right? Front, back of the left leg. That's also 18. Front of the left arm. So front, left arm is what? 4.5. Posterior trunk, that means your whole back, is what? 18. That's all. So we calculate this. What do we get here? So we have total body surface area 58.5. And it said the patient weighs 70, use the Parkland formula. What is the flow rate? That means how much fluid you're giving them in an hour during the first 8 hours. So we use the Parkland 4 cc times, it weighs 70 kilos. I did not do it in their test. I bet you they will give you in pounds and you have to go convert it into kilos. So learn the conversion, which is 2.2. Then times 58.5. What do we have? 380.
Yeah.
This is what you give them in 24 hours. So Parkland formula is always for 24 hours. They ask for the first 8 hours. So we divide this by 2. You divide the fluid into the first 8 hours and 16 hours. So you divide it into half and you get what? 8, 1, 9 something. Yeah, 90, right? 8190. This is ml. That's what you get. Half of this. This half should be run over 8 hours. And what is the rate? It will be like what? How much is it?
1023.75.
1023.75. This is not good, right? Every hour, the patient is getting almost a liter of fluid. You see, this is how much you give every hour, the first 8 hours. So every hour is getting like a liter of fluid. After the 8 hours, you can calculate, just calculate this for me, what they will get in the next 16 hours is the half of the, so 8190 over 16. That will give you, after the 8 hours, the fluid level goes down. And so you get better, 511. So, but even that, they're getting 500 cc ml every hour. That's still not small fluid. Some of us will go into heart failure. So this is just an illustration so that you can see how to calculate this in case you see it in your test.